Well, hey, everybody, this is Robert, and welcome to Outbreak News Interviews. Now, August is Psoriasis Awareness Month. Now, this annual observation aims to educate the public about psoriasis, a chronic autoimmune condition that affects millions globally, and to support those that are living with it. Now, joining me today to talk about psoriasis is Rosanne Paul, D.O. Dr. Paul is an assistant professor of dermatology at the Case Western Reserve University School of Medicine. Dr. Paul, welcome to the program.
Hi, thanks so much for having me.
Yes, ma'am. Well, let's go ahead and start with this. Let's give the audience a general overview on psoriasis.
Absolutely. So, for us in dermatology, psoriasis is a very common condition. Um, a lot of people, there's speculation, people will call it autoimmune, some people call it autoinflammatory, but it is a very common chronic inflammatory condition of the skin. Not only does it affect your skin, but it can also affect the joints. You can have one without the other. The hard part about it is once you got it for life. And so it is something that recently, I would say in the last 15 years, they've come a long way with research and treatment options. But it is something that is very treatable to the point that it may seem that it's, quote, cured, but is a very common thing that unfortunately a lot of people do deal with.
Right. And psoriasis is not just one thing. There's many different types. Can you go over that?
Yes. So there's more than one type. The most common type that people may be aware of would be what we call plaque psoriasis. So plaque psoriasis is red, kind of thick plaques that you would most commonly see on elbows, knees, scalp, ears would be common areas that we would see it. But other forms of psoriasis is a form called gut-tape psoriasis, where it's like teeny tiny little red dots on the body that we most commonly may see after like a strep throat infection. Other types include something called palmoplantar psoriasis, so that's where it would affect your hands or feet. There's something called pustular psoriasis or generalized pustular psoriasis. Those would be very common types of psoriasis that we would see.
Yeah. So you describe some of the typical manifestations.
Mm-hmm.
What are some of the more severe manifestations of psoriasis?
Yes. So I would say underneath those variants, so plaque psoriasis can cause something called erythroderma, which basically means that psoriasis is affecting greater than 90% of your body surface area, and your whole body is very red. So obviously, when that happens, there's a lot of inflammatory components that are going on in the skin. Generalized pustular psoriasis, which can cause erythroderma as well, can cause a severe rash where there's almost like lots of little pimples all over the body. And then palmoplantar psoriasis can be very severe, where it can be pretty debilitating to patients, where they would have involvement of both their hands and feet, lots of cracking, bleeding, pimple-like growths on the feet or hands as well, which can significantly interfere with their quality of life and ability to complete their daily tasks or work.
In psoriatic arthritis, this is a severe manifestation. Can you talk about that just briefly?
Yeah, so psoriatic arthritis. So as dermatologists, we have a lot of crosstalk with rheumatology. They would be the primary person who may diagnose your psoriatic arthritis. But typically, when we are counseling patients and deciding if they should see a rheumatologist, would be if they had joint aches or joint stiffness that would be worse in the morning. So when they wake up and feel more stiff and typically get better with movement, it can affect any joint. We can see it very commonly on the hands and feet. A lot of times clinical signs to us that there's joint involvement would be if the nails are also involved. So you can see some abnormalities that occur with your nails, which may be a sign that it's also involving the joints as well.
Yeah. And you kind of mentioned it, but basically, depending on the type, it can be found anywhere in the body.
Correct. Yes. Yeah. And so you could have psoriatic arthritis and not have anything in your skin. But you may have just your skin and no joint issues, or you could have both.
Yeah. Yeah. All right. I guess the biggest question is, what's the cause of this?
Yeah, so that's a great question. So we know that there's genetic interplay, meaning that if there is a family history, you may be more prone to developing it. It is immune dysregulation, and something triggers it. So like I mentioned before, for some people, it may be some sort of infection like strep throat, but we don't really know like what is the primary thing why we in the first place. We know what's going on in the skin and what the immune phenomenon is that's causing it, which is where a lot of the therapies that we're using now kind of interfere with that interplay. So we know that within the immune dysregulation, what happens is there's these inflammatory proteins that trigger our white blood cells called T helper cells. And they start secreting other types of inflammatory proteins that result in the skin to turn over faster than normal. So typically the skin takes about 28 days to turn over from bottom to top. And what's happening with psoriasis is it's actually happening in a shorter time period. So it's turning over faster than normal. So it's not maturing appropriately. So it's kind of sticking together and becoming thick.
Yeah. I'm not sure. This is a little bit out of your wheelhouse, but with psoriasis, I lost my train of thought. Sorry about that. Let me move on to the next thing. Diagnosis. So the patient comes into you. Is this strictly your expertise in observation, or are there laboratory tests to go along with this?
So they're typically clinical, meaning when they come in and they present with it in a certain area, it can be strictly clinical. You come in and you're like, yes, you have psoriasis. In some forms, especially like for patients who maybe are hospitalized and develop a rash where it's pustular and it's not clear, is this related to a medication or something like that? They may have a biopsy performed. A lot of times on the hands and feet, there may be some telltale signs like the nails being involved. But we may do a biopsy. There's no blood test that we order as dermatologists to signify like, oh, you have psoriasis versus something else causing this rash in your skin. Rheumatologists may order some blood work, sometimes just to rule out other inflammatory arthropathies. But for us, it's mostly clinical, but we will do biopsies occasionally if it's not 100% clear, meaning that it looks kind of like eczema, kind of like psoriasis, or do we think there's some sort of medication interplay that's causing this?
What's the difference in a biopsy of the two, eczema versus psoriasis?
So clinically, they can look a lot. Mostly where you're kind of trying to decide what's going on would be like there would be red, circular, scaly spots on the body. So the biopsy would show something called spongiotic dermatitis, which is basically swelling within the top part of the skin called epidermis. That would be something we would see more commonly with eczema versus psoriasis. We would see some thickening. There's also different types of blood cells called neutrophils that we would see in certain areas of the skin. So, and sometimes they'll come back and tell us it's psoriasiform dermatitis, which means it looks like both things. So it's not all, you kind of sometimes just have to go with your clinical gut over just the biopsy results. I oftentimes tell patients, you know, a biopsy is just me consulting with a physician on a microscopic level. So it's not always 100%. It can help guide us, but ultimately we kind of have to use all things together to make an appropriate diagnosis.
Yeah. All right, let me go ahead and swing back to the question I blanked out on when you were talking. I was thinking about it and then I lost it. And like I said, this may be a little bit out of your wheelhouse, but if somebody has psoriasis and it's an autoimmune disease, do they frequently have other autoimmune issues going on in their body?
Yeah, so I think it's a common, so autoimmune means like self-attacking self. So that's not really what's happening with psoriasis as opposed to something like lupus or something called dermatomyositis where your body is attacking yourself. Your body is dysregulated, meaning that it's causing these things, but you're not making antibodies to yourself. So generally speaking, it's not necessarily associated with other autoimmune conditions, but other inflammatory conditions. Some things that are actually commonly associated with psoriasis are like metabolic syndrome, diabetes. Those are all common things that we may see more frequently with psoriasis because we know systemically there's inflammation. Although it looks like it's just your skin, we know you have systemic inflammatory components that may be also associated with increased risk of cardiovascular disease like heart attack and stroke. But generally speaking, as far as other autoimmune conditions, not necessarily, no.
Yeah, I guess one of the other most important questions is, the availability of effective treatments. I'm sure this has progressed over the years. At one time, it was probably just creams and,
Yep.
and stuff like that. What's available now?
So there's a lot. That's the wonderful thing now, is that like there's so much more available. So unfortunately, some of that is dictated by your insurance, what they'll let you use. But so it's kind of like step therapy. If you've never used anything, you have a small surface area, yes, you can do creams. We can do, which are typically like steroid creams or topical vitamin D analogs. And then there are some non-steroidal creams. We can also do localized injections. So say you just have like a really stubborn area on your right elbow, we can directly inject that with a steroid. You can do light treatment. So light treatment is typically coming into the office and we do it's called narrowband UVB. So, or phototherapy, come in 3 times a week, you can do that. And then beyond that, you're talking about systemic therapy. So old school therapies, cyclosporine, methotrexate, acitretin, yes, they have their role. And
Oh,
when we're at response in studies, there's something called a PASI score, which basically tells you how great are we doing on this therapy. So back in the day when the only thing available were those treatments and maybe Humira, people were getting like PASI scores of 50, meaning probably about 50% better than what they were. Newer treatments now with injectable treatments are those inflammatory proteins I was mentioning earlier that are involved, and we know more about those. A lot of the therapies are targeting those now. So that would be like, to name a few, would be like Skyrizi, Stelara, Taltz, Cosentyx, and honestly, there's more that come out every single day. Those would be things where we call them biologics, where you're injecting yourself. Frequency of injection varies depending upon which medication, but you're seeing PASI scores as high as 75, 85, 90, 99. So a lot of these people are getting near complete clearance, which they never had previously.
oh, that's great. Wow. I guess you kind of already answered it, but is there a way to prevent it?
So you can't really prevent it. The
I mean,
downfall is,
if you know your parents had it and you're a teenager, it's
yeah,
like
that
nothing.
would be amazing. That would be amazing, but no, you can't.
Yeah. All right. And let me go ahead and close with this. This month, August, is Psoriasis Awareness Month. Would you like to go ahead and talk about the importance of this month, at least to you? Yeah.
Yes. So I think it's great because it increases the awareness to the general population. Number one, what is psoriasis, right? So you saw somebody at the pool who had red scaly legs and you're like, what is that? I don't want that. So it generally increases awareness, not only of what it is, but also what we can do to treat it. Also increasing the population who may have a rash and are negligent to it and maybe have arthritis, and increase their awareness that there's many treatments available to them, and to encourage them to seek treatment for it. And then the third thing is obviously for them to know that they're not alone. So there's a great websites like the National Psoriasis organization that you can find online. And there's a lot of support groups for patients, so that they, can relate to others and talk to others about what they're going through, whether it's their treatment, their joints, their skin, and just find other people who can relate to them in that circumstance.
Very good. Well, I want to thank you, Dr. Rosanne Paul, for sharing your time and expertise with me today. I appreciate it, ma'am.
Yeah, no problem. Thank you.
All right. Bye.